Okay, look, I can't see.
Okay, in the meantime, I'll start the first one.
He can see. He's younger than
Of course.
I am.
Better maintained. So it says, Dr. Jog, did we understand you say the levodopa does not reduce tremor? That's the first question. And I would say about 60% of patients get a good response to levodopa, response to tremor with levodopa, but there's a significant number of patients that don't. So the other issue is that patients have a variety of symptoms, as we said, stiffness, slowness, tremor being just some. Levodopa response is not the same for all the symptoms, which means that the rigidity, bradykinesia, gait, shuffling, etc. might respond much better to a lower dose than tremor. And so often what ends up happening is that you have a lower dose that you treat, and then you're stuck with just the tremor that's residual, and the only option you have is to increase the levodopa much higher to treat the tremor. And we don't want to do that because then you're on a higher dose for one symptom and you run into this dilemma. The last thing I'll say about levodopa and tremor is that because stiffness and slowness respond better, you actually loosen the person's frame in a way. And tremor can actually worsen, in the initial treatment. It's kind of like the example that I use. If you loosen all the screws in the chair that you're sitting on, of course, what will happen is it'll shake. So that's not actually something that does happen, and patients do complain to us saying that I thought you were going to make me better, but I'm worse because I'm shaking more. And that does happen with levodopa. And the second question there, if that's the case, then why am I taking levodopa when tremor is my main symptom? Good question. Right? And so, in fact, this is the reason why we have designed this entire kinematic technology to be able to use botulinum toxin injections to treat those patients. So we have a cohort of 25 patients that we've now followed for 3 years who are on monotherapy injection only, just monotherapy injection. Right? So no levodopa, no other Parkinson medications because tremor is their prominent symptom. Now the injections are only in the upper limbs, not in the lower limbs. We can inject head and neck and upper limb, but we don't inject in the lower limb because the amount of toxin required is too much.
And do you think, even looking at that tremor in lower limbs, how much does that impact somebody? Hand tremor, yes, it impacts functionality and so on, but leg tremor, not as big a deal.
Exactly.
To deal with. Yeah. Okay. And the other thing that I was going to mention about the tremor management idea is that one of the things that I talk about when I see people is how much of an impact does that resting tremor have on your functionality? It's noticeable, it's something that draws attention, it's something you're aware of, but in terms of being able to do things, it probably doesn't affect you as much. It's more the bradykinesia, the slowness part.
Yeah, absolutely, that's correct. Cosmesis of tremor is the big thing, and especially people that have a big tremor, then it does affect the look of the tremor, and it is disabling for that reason. But you're right. Yeah.
Right. Great. Shall I move on to my question?
Yes.
Have a look at that one, and we'll toss it back and forth. But that just came up. But I'll go with mine. Okay. So everybody wants to know about this. Can anybody guess what I'm about to talk about? So the question here has there been research done with medical marijuana for adding in the symptoms of Parkinson's, and if so, how has it helped? My first comment about this, I'll be a bit glib about this, but my first comment about this is I have yet to find a neurological or medical issue where somebody doesn't think that marijuana is a good idea. Right? Everything, right? And so when something seems to be proposed for everything, my suspicion is that it works for nothing. So I'm not going to throw it out completely, but what we can say about this is, as of now, there have not been any controlled trials, the things that we call double-blind placebo-controlled trials, of the use of marijuana in treating Parkinson's, the core symptoms of Parkinson's. The other thing to understand about with the marijuana issue is the differentiation of the compounds that are involved. Now, there's many, many compounds in smoked marijuana, but there are two major neurochemical things, the tetrahydrocannabinol, or THC, and the cannabidiols, or CBDs. There's a differentiation between what the THC and CBD offers. So there's well-known stuff from other areas of neurology and medicine where CBD, the cannabidiol component, is useful in pain management, for example, perhaps appetite stimulation, perhaps relaxation, and so on. So there are lots of areas where it's being used, and also in epilepsy.
Yep.
So there's some clinical trial data that shows that in certain cases of epilepsy, severe uncontrolled seizures, that medical marijuana, CBD in particular, may be helpful. So it's not as though we want to just throw this out entirely, but what I'd have to say about it, as of now, We don't have any clinical trial data that says here's where it works. There's lots of anecdotes. There's some videos on the internet. You've probably run across those videos as well, where a certain fellow with dyskinesias is given a medical marijuana compound and his dyskinesias go away. But the problem with that as a trial or as an explanation is if he had a chocolate bar, his dyskinesias might have gone away as well. And not because it's chocolate bar, because I just picked that out of the air. He could have had a tart, piece of ice cream, a pie, a sausage. The point is that many of you who have dyskinesias know that it may be linked to the timing of your medications. You get a peak of dyskinesia and then it goes away. So anything you do at that time where the dyskinesias are coming on, you can't be sure that it's actually treated the dyskinesia. So it's very dangerous to look at an internet video like that and say, oh my God, I've got dyskinesias, I should be on marijuana right away. There may be other reasons you want to try marijuana, but the bottom line here is there's no clinical data that shows that this is useful yet. There are some interesting neurochemical things. We were talking about this, Dr. Jog and I were talking over lunch about there are receptors in the brain for THC and CBD. So the question is, well, what's involved with that? But we don't know. And what we have seen in some of the basic science research about this is theoretically, given where these receptors are found and what the circuitry looks like, medical marijuana might actually worsen dyskinesia. So there's a lot of uncertainty about that.
Yeah, I know nothing more to say. It's exactly correct. Yeah.
Fantastic.
Yeah. Excellent. So the next question is, what research is being done in London on the connection between Parkinson's disease and autoimmune disease? So this is an interesting topic in terms of what we said, the causation in the first 2-3 slides that I had of Parkinson's disease is. And one of the ideas that Parkinson's disease is an inflammatory disease, that it's because of inflammation, because of something that triggers cell death. One of the reasons that this is a very difficult field to investigate is because we don't have pathological material, nor do we have animal models of typical Parkinson's disease with inflammation. Remember I said that post-encephalitic Parkinsonism, so patients who have influenza and now Japanese B encephalitis, that's an infection which creates an inflammatory response and causes Parkinsonism. However, most typical patients with typical idiopathic Parkinson's disease have never had those infections. Could they have had subclinical infections, which triggers? Very difficult to know. So because we don't have good pathological or animal models of idiopathic Parkinson's disease showing inflammation, it becomes difficult to know whether inflammation is directly causing death of those cells. And if that's so, why those cells? If you look at the pathological material from autopsy in patients who have passed away with Parkinson's disease-like conditions, then you will find that around substantia nigra, there are a lot of inflammatory cells, especially cells that are called microglia, right? And so there's been a lot of interest in microglial activation, and hence you turn down microglial activation and then reduce cell death, etc. So about 20 years ago, the NIH had a clinical trial with Celebrex that was going to be started as an anti-inflammatory to reduce inflammatory or inflammation-related cell death. But ended up being that the toxicity that was supposed to potentially occur with Celebrex was more than the expected improvement, and so the trial never went ahead. And so we really haven't had any more. But there's been a recent resurgence of this, and in fact at Lawson, Dr. Frank Prado and group there, and I'm involved in that group in terms of advising them from the PD perspective, are looking at immune markers that potentially they can use in PET scanning, that they have a PET scanner at Lawson, to see whether certain markers of immune cells will bind to degenerative brain cells more so early in disease versus late in disease. So we did apply for he applied for a grant to Michael J. Fox Foundation, letter of intent. I think it was 2-3 months ago, but it was rejected. But so in London, that was the question being done in London. That's where we're at. I'm not an immunologist, and so I don't personally do that kind of work. But this is where the field is here in London, anyway, with respect to that.
There was a marker, and I can't remember the name of it now because it was a PET marker a number of years ago, and I think it was one of the guys from the Hammersmith,
yes, that's right,
had shown with the PET study and the microglial marker that it lit up. And I asked John Stossel, a friend of ours from Vancouver about that a number of years ago, and he said the problem with that is it wasn't replicated.
Yes.
So we couldn't get another study to show the same thing, and then it became problematic. Well, is this actually doing it or not?
Yeah, and then the issue is that is inflammation friend or foe, right? Because you want inflammation if you've got, like I've got this bad sinusitis. I hope that my inflammatory things are actually working.
Are these chairs far enough apart? Not far enough apart.
Yeah, no. So the thing is that the idea is that are the inflammatory markers simply trying to help the cells, and when do they become foe, right? And so that transition is so difficult because the cells may not necessarily change. They simply now are becoming destructive as compared to constructive, right? So that's, and at which stage do you image? By the time you get a clinical diagnosis of Parkinson's disease, maybe it's already past the stage of picking up the inflammatory markers, and they're there. So you don't know whether they're there to help because the degeneration is occurring, or whether they're causing the degeneration.
Tough stuff.
Yeah.
And that kind of feeds into the next question. We had a question about that even backs this up even further, and that is this kind of emerging stuff lately that is the first pathological event in the gut.
Yeah.
So is there some gut problem that leads to sensitization in the appropriate population that then results in an inflammatory response in the brain and subsequent deterioration into the condition that we recognize as Parkinson's? And I think I was at a meeting, I think must have been MDS Berlin a couple of years ago now, and it seemed like every other poster was talking about gut inflammatory. So there's something emerging, but we don't know where it is just yet.
So this is interesting because the reason that this has come about is because of the constipation issue that predates Parkinson's disease by many, many years, and saying that constipation may be a marker of gut pathology. Hence, so I made a joke at a talk I was giving to a university alumni years ago. It didn't go across well, and I said that if that were the case, then if the incidence of Parkinson's disease was high in people that were constipated, then the incidence would be very high in the hospital administrators that we have. And nobody laughed, and it was very bad. And so, moving on from that. No.
So, boom, we're here all afternoon.
Yes. So what I did want to say was that there's been a lot of interest in the fact that if you do gut pathology by biopsy, that alpha-synuclein protein accumulation is seen in the gut. But the problem with that is that a lot of recent literature has debunked that. So in fact, in control populations, if you were to take population that does not have Parkinson's disease clinically, and you were to do gut biopsy, then 95% of those people have alpha-synuclein, the same abnormal protein that accumulates in Parkinson patients, but it's in people that are otherwise normal. Right? And so that's been debunked. So we're now not considering, that's why I said in my slide, doing gut biopsy or bowel biopsies for that. Whether an inflammatory, and then the last point I'll make is that because of the fact that the vagus nerve, which comes from the brainstem, innervates the gut, the thought is that something enters, causes inflammation, something enters to the gut, causes inflammation, is picked up by the vagus nerve and transported directly to the brain that way. That's the theory, never been proven.
Yeah, and mechanism, again, we talked about this idea, what's the scientific mechanism behind that? How would that be? How would that work? What would that look like? We don't have anything.
We don't have that. It's never been shown in animal work.
So I remember facetiously saying at the meeting that we saw this, as I thought, everything's going to turn out to be caused by the gut problem. So, but it is our interaction, it's a big interaction with the environment. So, do you want me to go again, since that was a kind of go thing, or you go ahead?
No, you go ahead.
All right, let me see. Okay. Oh, okay, well, this is kind of good, all right. So I understand Parkinson's disease is highly misdiagnosed, as other diseases tend to mimic Parkinson's. What are some of the other diseases that are similar in manner to Parkinson's, and is testing similar? Okay, well, that's a very good question. I'll start off with what I always talk about when I see somebody, and I say, based on clinical examination and historical findings, so what I can, take a history from you, what symptoms you've had, how long you've noticed them, what things have been involved, and what I find on examination, if I see certain things, I can be a percentage accurate in a diagnosis. And what I usually quote is the UK Brain Bank stuff, right? So if I say, I see you with, this is no good, is it? There, is that, no, am I on? No.
Yeah. Is the clip not working, or?
No, it's me.
Oh.
It's me. Not the clip, it's me. So the issue, it's okay. What I say is I'm about 75% accurate in making a diagnosis. If I see certain symptoms on exam and listen to things in your history, and I say, I believe this is Parkinson's, I have about a 75% accuracy. That's based on those symptoms and what I find on exam. There's really no other testing needed, necessarily. Now, there are things we do because we want to exclude certain things. So I look for blood test abnormalities. I heard Dr. Jog talking about vitamin deficiency, things that can cause problems. I look for inflammatory things, connective tissue problems. I usually do imaging of the brain on the off chance that maybe we'll find something different. So what I say about this and the way I want to answer this question is I start off with saying I'm about 75%. And then that doesn't mean 25% you don't have anything at all. What it means is 25%, this might turn out to be something that looks an awful lot like Parkinson's right now, but changes. And there are some mimics. The most common mimics are conditions that we have various acronyms, and we have the acronyms because the longer version of them is a lot harder. But one of the most common ones we see is a condition called progressive supranuclear palsy, or PSP, where it looks an awful lot like Parkinson's initially. You think, well, maybe that's Parkinson's. Okay, yeah, you've got these symptoms, you've got this history, that's good. But it tends not to respond to medication. So there's others. There's a condition called multiple systems atrophy, and there are a couple of types, things like that. So these are some of the mimics. Now, other things, I think one of the commonest mimics of Parkinson's that doesn't get addressed or identified is vascular. Something called vascular Parkinsonism. We sometimes call it lower half Parkinson's because it tends to affect the legs more than the upper extremities. It tends to be more slowness than tremor, and usually bilateral, but not always. So one of the more common mimics of Parkinson's disease, the entity idiopathic Parkinson's disease, would be vascular Parkinsonism, and then some of these other conditions that we call Parkinson's plus disorders. That means they have some symptoms that look like Parkinson's plus something else. Anything you want to add to that?
Yeah, the first thing I heard was you have a 75% accuracy in making diagnosis. We can help out with that. 6 months in the clinic in London, we can bump that up a little.
Get about 80, 82? Is that? I was happy with 75. They worked all through high school.
Different in London. We're about 90, 95. So no, the one other thing that I would actually add to that is essential tremor.
Oh yeah.
Right?
Okay.
So
Yes,
all that is because many times we get patients that have had tremor for several years, and now they've become slower. Is it ET, or is it ET plus PD, or is it just? So that's why I told you about that condition, benign tremulous Parkinsonism, which actually is Parkinson's disease, but it behaves much more benignly. So that's not the same as tremor dominant. These are people that have tremor. They otherwise look like Parkinson, but just the other symptoms just don't progress. So that's another differential diagnosis of Parkinson's disease. Yeah. Okay, so what research news is there? 3 questions, but basically related to looking at diffuse Lewy body disease or...
Can I add one thing that I forgot?
Yes. Oh,
I'm so sorry. No, I should have mentioned it at the end, because the end part of the question was about testing. And what I said was, clinically this is the big thing. Yeah, we do some imaging stuff. And you can perhaps get an idea from imaging, from MRI.
Yes.
To differentiate between Parkinson's and some of the Parkinson's variants. And there's some emerging stuff that you guys are looking at more with the high Tesla magnets, where we can get a little bit better imaging quality of the brain with an MRI that might actually get us more certain about a diagnosis. I just forgot to mention that.
That's absolutely right. And I'd said in my lectures that we don't usually image anybody unless you have, you want to look at you don't often, don't always find anything that correlates with PSP or MSA, but if you do, then it does sway the diagnosis very much so. And why does it matter? Well, it matters because the outcome and therapy and all that are different in patients with those other conditions as compared to Parkinson's disease.
And course.
Yes, and the course of illness, yes. So then going on to diffuse Lewy body disease, Lewy body dementia, and Parkinson's disease. Well, the problem is that all of what we do is finally based on criteria for what we label the disease as, right? So if somebody has, as Dr. Stewart said, UK brain bank criteria, asymmetry, bradykinesia must be there, plus or minus rest tremor, etc., well, we call it Parkinson's disease. If you have, we call it. So when it comes to a diagnosis such as diffuse Lewy body disease, that actually is a pathological diagnosis. In fact, cannot make a diagnosis of diffuse Lewy body disease clinically. It has criteria that are all over the place every time. First year of hallucinations, dementia early, with Parkinsonism, with
Daily
not
fluctuation.
Yes, fluctuation. The problem is Parkinson's disease is actually a clinical diagnosis. Remember what I said, right, in the talk. Diffuse Lewy body disease is the pathology that you see in the brain when you do an autopsy of having this thing called Lewy body or Levy body diffusely, right? So we don't actually have the patient's brain when they're alive. Right. So you've got a diagnosis that's a pathological diagnosis in a person that's got symptoms, right? So it is actually not the right way to say. So what you're saying is this individual has symptoms like tremor, bradykinesia, etc., and PD of cognitive decline, hallucinosis, mild Parkinsonism early. We have to give it another label because until you get pathology, you can't say diffuse Lewy body disease.
Yeah, and so, I get that question a lot. Well, how can you be sure?
Yes.
And the answer is I can only be sure when I can look at your brain when you're done with it. And
yeah,
that's not feasible.
No, I mean currently.
Often in my office, it's not
easy to do.
Not
yes,
easy to do.
No. And in fact, jokes apart, we don't do biopsies and things like this in patients because this is not something that's diagnostic. So whether a patient with Parkinson's disease that has Lewy bodies and degenerative changes in the substantia nigra, where dopamine is, at the later stages, does that pathology spread and become diffuse Lewy body, i.e. Lewy bodies from nigra going diffusely, or is diffuse Lewy body disease an early version of this that occurs in the cortex? Well, it's chicken and egg. I mean, we really don't know. It makes a difference in terms of outcome because obviously you have cognitive impairment early, hallucinations early. That makes treatment of the motor symptoms very difficult because many of the drugs that we use worsen those aspects. From that perspective, it's important to be able to differentiate between the two as we did with the PSP and others. But other than that, it is very similar in terms of the pathogen or pathology that we see.
Mm-hmm. Yeah, and we just, depending on the symptoms we need to address, we just choose medications to try to address those problems. And whether, if we get into trouble where we're treating the motor symptoms and finding these other problems, well, there are some ways around that we can approach. But to say, and I get this a lot because I see this from some clinics that they say, oh, well, this person has dementia with Lewy bodies or DLB. And I think, well, you don't know that for sure.
Yes.
Because, as you say, it is a pathological diagnosis.
Yes, exactly.
Very much. Okay. All right. So after a certain amount of time, doesn't levodopa plateau, 1 to 3 years depending? How much? Okay, well, I'll deal with that. There's two parts to this. So I always talk about this and say that we use levodopa to replace the missing dopamine that I know Dr. Jog has talked about previously here and the different mechanisms, different preparations that he talked about that are kind of exciting for us in terms of management. So the bottom line is that levodopa works and continues to work. So it's not a question of the drug itself failing, it's a question of the brain changing. So it's a question of the substrate that we're dealing with. Unfortunately, to date, we don't have treatments that can stop, slow down, or even reverse if you'd like, but to stop the pathology that takes place in Parkinson's. So these neurons in the substantia nigra, these dopamine-releasing neurons, are continuing to sputter out and stop working. That's the change that leads to the failure, if you will, or the decreased benefit of levodopa from working. It's not the drug itself. So if you waited forever, not a wise idea, and I think there's a question coming up about that, about how long do you wait or so on, about treatment. But it's not a question of the medication itself. If you waited forever and didn't take your medications, it's not as though when you decide to take the medications, you can take what you could have taken 5 years earlier and gotten just as well. You're going to have to take more to get there. It's a deficit. So what the deficit is that we have to replace. And yeah, it is true that over time, the efficacy, the efficiency with which levodopa supplementation helps does change. And it requires us to change dosing and change schedules, change preparations, change administration methods.
Yep. I mean, I think all that's exactly correct. And the medicines that we use, which ties in very nicely in terms of this next question, which is what is essential in Parkinson care and monitoring? Well, So what is critical in monitoring is your expectation of your quality of life is the first thing, because all of the treatments that we have currently are to improve the quality of life and functioning, right? So that's the contract that I say I sign with my patients, is that you have to guide me as to what you expect your quality of life to be within reason, and my job is to use the medical, whatever repertoire we have and medications to be able to optimize that, because what I might see as wanting optimization may not be what you see.
Yes,
and that's where the idea of tremor comes in, right? I look at somebody that's got a tremor. I'll give you an example of years and years ago, one of the Supreme Court judges was a patient of mine, and for her, having even a minor tremor sitting on the bench was just not possible, because she would feel that she was not functioning, other people were doubting her judgment, etc. And that position, we had to treat her, because otherwise her quality of life, which to me would not have really been affected in any other person with that little bit of tremor, was destroyed. So here's targeted therapy. The first thing you want to monitor is that, your quality of life. Why? Because the drugs are used to optimize that. Second, you need to monitor how you take those drugs, right? So you got to take them properly the way the physician, hopefully knowing what they're doing, the movement disorder specialist prescribing them. This is an important point, because there are many other people that are telling you how they are taking their medicine, including the pharmacists that are telling you how to take the medicine, and then you decide what is convenient to you and take the medicine, and then it's all over the place, right? And it's very funny, because I've done this, as I said, for 24 years now, and I've told patients every time, 1 hour before meals, no protein, etc. But 6 years after I've been treating this person, said, nobody ever told me. I said, well, okay, well, just when you came is when I had that little, lapse in my ability to tell you. But I tell everybody, right? And so that means you're not monitoring what you're doing. The other issue is the pharmacy. Pharmacists will tell you to take it with food, right? And that normally translates to meals. And that's not what you're supposed to do. So the second thing to monitor, besides your own quality of life, is the medications. The last, there's a top 3 things, but there are 11 things, but the other top thing is to monitor whichever symptoms you have, depending on the stage of the illness, because it changes as you progress through the disease. So early in the stages of disease is optimization of function. Later on, it's safety. So swallowing, balance, falls, cognition, etc. All of those things that are now in the later stages of Parkinson's disease that you didn't need to monitor early on have to be monitored. So pay attention to where you are in the response of your medicine and stage of disease, which would be the third thing I would monitor.
Yeah, I have a similar story like that. When I first started in fellowship, we had a fellow who was in his 40s, I think late 40s at the time of diagnosis, and his symptoms were minimal. So if you did a UPDRS scale, the motor scores were minimal for him, and the impact was minimal, but he was an amateur triathlete, and for him it made a difference swimming. So at a time when we wouldn't have bothered treating someone with that level of dysfunction, for him it had an impact. It had a quality of life impact for him. So we put him on treatment at that point.
And this is what in the last decade or so has become called, the FDA has called the GAS scale, not the gas, it's a goal attainment scale, right? Goal attainment, right? And this is something that we actually don't ask patients usually, but we do in our clinic. What is the goal? What is it that you're looking for? Is that realistic, right? What are the adaptations? The reason that's important is because, thankfully, Parkinson's disease is a slowly progressive disease. And the problem with that is that you make adaptations to your quality of life that you may not even know you're making. So last summer, I had to go, let's say, walks every day. Now it's gone down to twice a week. By next year, I'm not really going out for a walk, but it's taken a year, and winters happen in the middle, and you kind of just have forgotten that 3 years ago, that's what your quality of life was. And hence, you don't tell me, because it's kind of like I tell students, if we make 75% as 100%, which we seem to do these days, then everybody's stellar, right? But no, everybody's mediocre, actually, is the reality. And so this is the difference. So you got to be sure that you are actually truthful in terms of what you've not done anymore or not doing anymore in quality of life. Yeah.
So I have another question that gets to your stuff about botulinum toxin injections for tremor. How much does it cost to get injection of botulinum toxin? Well, yeah, that's an issue. The compound itself, fairly expensive, Now, some people have private insurance plans that might cover them. Many of them are getting very specific these days and asking exactly why you're using it. And in this situation, we don't have an indication.
That's right.
So when we deal with medications, we have what's called a clinical indication. So if there's a certain medication that's used for something. So for example, levodopa is used to treat Parkinson's symptoms. It has an indication for that. And you can justify using that. But right now, botulinum toxin, the injection stuff, doesn't have a clinical recognition as an indication to treat tremor. We have it to treat facial spasm, neck spasm, spastic limbs, headache even. There are lots of issues where botulinum toxin has an indication. So when it has an indication, then an insurance company, or in many cases OHIP, the OHIP insurance, ODB insurance, will pick up the cost of the drug for you. In this situation, not so much. So what's the cost? Well, it depends on how much we're using. It's an amount per unit. The vial of botulinum toxin, 100 units. It comes in 50s or 100s or 200s, depending on the company you deal with. And it's not us that's doing this. This is the cost to the pharmacy. So if I give you a script and you go to the pharmacy to get your botulinum toxin, for 100 units, you're going to look at about $400. Now, if we're talking about treating an upper limb spasticity, we might be using 100 to 200 units.
Yeah, so I use Xeomin because Xeomin, the company that manufactures it, gives you a discount, so it's about $320 for 100 units. And on average for tremor, for the upper extremity, we use for one limb somewhere between 100 and 150 units. But I normally tell people that for both arms, if we say 400 units, that's about $1,200 4 times a year, right? So at the moment, but it could be half of that. So between, for years, for the last 3-4 years anyway, I've basically been not telling patients that are not, in our study. But in the last, literally the last 3 months, I've suggested it to people, and I've had a large number of people say, oh yeah, well, that's $4,000 a year. I divide that and whatever, and that actually I can afford that. So I was denying people the choice because I thought, $5,000 a year might be too much for people. But there are a lot of people who are saying, in fact, I'm getting patients from Toronto being sent because they want to pay for it. Yeah. And I can imagine if somebody's spending $3,000-4,000 a year because their arm is like, or especially for essential tremor, I can't drink coffee, I can't eat food, I'm not going out because things are falling on my. Then your quality of life is so impaired.
And the cost may be.
Yes. Yeah. And or for example, we were talking to somebody before lunch. Not with botulinum toxin, but the individual said, I couldn't sign. Now with whatever treatment I have, I can sign. So to you and me, that might not be such a big deal, but for somebody else, that's a huge deal. Yeah. And we've had patients who've had a significant improvement in their tremor. So if you're willing, that's about what it costs.
Right.
Yeah. So yeah, the next is exactly how should I take levodopa for best results, how often? Well, I sort of answered that in a way, but levodopa, as I said, is made up of 2 compounds. So the other compound in it is carbidopa. There's another version of it which has benzerazide. Those drugs allow levodopa metabolism in the body to be slowed down, the breakdown to be slowed down so that it can actually get into the brain. That second medication requires a particular amount to be taken. If you take half a tablet of 100/25 twice a day, that's not going to be enough carbidopa to be able to block that enzyme that we talked about, the AADC enzyme that we talked about. If you don't block that enzyme, then you basically are wasting your levodopa. You take it by mouth, so that's why the blue pill, the 100/10 pill, should not be used at the starting dose in anybody. Because if you use the 100/10, 3 times or 4 times a day, you're still getting too little carbidopa. How much you need? You need a minimum of 75, some people even say 100 of carbidopa before it effectively blocks this AADC in the gut and liver and muscle, right? If you don't block enough of it, then there is not enough to get into the brain. Right? So I usually prescribe at least 3 times a day and many times 4 times a day, not through the night, but usually 7 in the morning, 11, about 3 and 8, or some people get 7, 12, and 5. 1 hour after that you can eat. That's my pattern. That sounds reasonable?
Yeah, absolutely. I early on, because there can be some nausea, I'll say, look, take it, if you feel more comfortable, take it after meals. We'll get started that way, and then we start to deal with the meal and protein interaction thing. But absolutely. And it is often the case that people are, well, first of all, there's a lot of people who are afraid to take a medication. which is a common theme. I get that. But apropos this point, you don't want to take so little that you're not actually getting anything at all, and you might as well not.
Yes.
And then if you're able to not take the medication and function apropos your quality of life, well, fine.
That's right.
But if you're in a position where medication is needed, take the amount that's needed. The amount that's needed, though, is as variable as the number of people that have this.
That's exactly right.
And
that
I also
actually
get that.
is this next question. What are the downsides of staying off meds as long as possible?
Right. Yeah.
So you want to continue on?
It's about quality of life. There may be, and there are certainly circumstances where I see people who have perhaps minimal or modest symptoms that you're able to cope with, a non-dominant hand slowness that you can function with. And in that case, do you need to take medication at all? And that'll be a question that I'll ask. Do you need to take medication at all? Getting at this idea again of quality of life. When you do need to get into taking medications to improve quality of life, then we address how much you need and how long it lasts and so on.
Absolutely. Absolutely.
Yeah. Okay, so do you want to move on from that?
Yeah, I don't think I have really anything more to add to that. Yeah.
Okay, is that good?
I'm done with my questions. I've got
Oh,
one
well,
more.
here, I have another one.
Oh,
Oh, yeah, no, he's the host, right? Okay, so does the brain trick the feet into freezing? This will probably be you,
Yeah,
to talk a lot
sure,
about
sure.
freezing stuff. But does the brain trick the feet into freezing? And how do we overcome that? And are we supposed to take B12? Will this help? I think that's what it says. I'm not sure. Okay, so let's answer the first part. Does the brain trick the feet into freezing? Well, it's actually an interesting thing. Freezing of gait's a very complicated, well, of course, you can say that about anything. And unfortunately, every time we talk about the brain, you can just say, okay, look, it's really complicated. Because it is. And if you think it's complicated, it's more complicated than that. So, but does the brain trick the feet into freezing? Well, what happens in freezing is that the signal, the volitional I want to move, to coordinate with the actual circuitry that gets your muscles moving is kind of disconnected. I call it a short circuit. So you don't make the connection between I want to move and I then get up and move. So there's this disconnect. And what you have to do to get around that is to think of other ways. And that's why we talk about things like think big, think loud, make big steps, think about music, get into a cadence, that kind of stuff, where that's a way of tricking it. So the question is interesting because the question says, is the brain tricking the feet into not moving? It's actually the other way around. We're trying to trick the feet into getting going. So it's kind of an interesting question in that regard.
Yeah, I think you've really, there are many complicated ways, again, as Dr. Stewart said, to answering this question, but that was a very good answer because, and the problem is that in our upper limbs, we don't have a phenomena that we have in the lower limbs, which is the ability to walk coordinated like this, right? So when we became bipedal, right, from quadruped to bipedal, we allowed our brain to be able to control our upper limbs very differently, right? So I can do very different things with my upper limb. Legs, on the other hand, have a very stereotyped gait coordinated. That's what we do. We don't do very much else with the legs most of the time, unless you're complicated dances and those kinds, which you can
yoga
retrain.
instructors.
That's right. So the problem is that those control systems are not the same, upper limb versus lower limb. So many times, upper limb symptoms respond to dopamine very well. Lower limb symptoms often don't, right? Because they're not controlled the same way. Some dopaminergic control is there, but often there isn't enough dopaminergic control. So what we see in patients is that, yes, you get off freezing, which means that you basically stop, but you also can get, quite commonly, on freezing. That means everything else is good, but you're still stuck to the floor, because that phenomenology is not related to dopamine. And so the interesting part there is that, remember we talked about progression of disease. So in gait freezing, we feel that it's outside of the dopaminergic system that freezing is actually occurring from, and hence typical Parkinson's medicines are not working, which is why we started doing the spinal cord stimulation program for that, is to be able to get around that dopaminergic system, right? And so it's a phenomena outside of the dopaminergic system.
And that goes to this thing that our friend Andres Lozano in Toronto was trying to do, looking at different targets in DBS, in deep brain stimulation, different targets to treat freezing of gait.
Yes.
And there was some little success. But not enough to keep it.
Right, and it's a much more risky procedure than our spinal cord stimulation, which is an outpatient procedure.
Very good. Yeah. So I finally figured out what this said, and I apologize. Are we supposed to take vitamin B12 with levodopa? Well, the thing is, I've long ago decided that, or seemed to indicate, looking at patients that I saw in their B12 levels over the years, that we're all deficient. So I just about tell everybody, almost everybody, to take some B12. Because what the labs report as normal may have more to do with hematologic function, blood function, than with neurologic function. So I tell almost everybody to take B6, B12, and D typically. In my
and so just about 2 days ago, we had this conversation in our lab and clinic as to what happens. And I briefly mentioned this homocysteine levels that go up with levodopa metabolism. And if you're below 400, 500, which is the upper end of the limit of what people are reporting as normal B12, right? People have 150. Somebody's got a B12 level of 150. It's still above 120, which is the lower end of normal, but it's low, right? So we supplement that to keep the level up at about 15. And I use methylcobalamin, not cyanocobalamin, right? So methylcobalamin to supplement. And yes, I think it's a good idea to have your B12 levels measured maybe regularly and then supplement with that, Yeah,
very good. Okay. Well, I have one more question
finish
here.
It.
This one says, I'm not happy with my current neurologist, and for that I profoundly apologize.
Must be him.
It could be me. So Amanda's taking patients, but can I change who I see, and if so, how do I go about doing that? And, there's always personality clashes, right? We have certain personality traits, and there are certain things people like about me, and then you rate my doctor, and there are certain things they don't like. But having said that, if you want to see somebody else, and I should back this up by saying not everybody with Parkinson's sees a movement disorder specialist. Many don't see a neurologist at all. And I think if you do have this diagnosis, if it's being considered or if it's something that you want to explore, you should see a neurologist. And ideally, you should see a movement disorder neurologist if you can. There's not a lot of us around, but we're around. I'm in the community. I'm in Cambridge. I see people from everywhere. How do you go about doing that? I think it's as simple as approaching your family doctor. We all need a referral. That's the requirement by OHIP and the rules that govern our functioning. So we need a referral. That means you just say, look, I'm going to so-and-so, I'm going to see Dr. Stewart, hate him. I'd like to go see somebody else. You just ask your family doctor, can I see somebody else? And look around. You can talk to the Parkinson support people here who can tell you who are movement disorder people in your area who might be, most of us, I think everybody's accepting patients. I don't think anybody isn't.
Absolutely. So. Yeah. I mean, even in London area, we've got people that trained with me that are in community practice. So they should be taking patients. Our waiting lists are long, but we've never closed our practices. And that's it. That's the way to do it, is to ask for another referral. Sometimes people are reluctant. I do agree that patients are, the family physicians can be reluctant, but you have to push because, as we said at the start, that's the kind of care that you need.
And if you are seeing, and there's nothing wrong with lots of our colleagues, general neurology, that's fine, it's okay. But if you feel like, I'm seeing I'd like to see somebody who specializes in this, I think that's fair game. That's fair to ask.
Certainly, I really push for the younger populations to see us because we can offer all those advanced therapies that are not available. If you're 85 or more and sound, there probably is not really any reason to come all the way down to see us. But at the same time, if you're 65 with new onset Parkinson's disease, you've got 20 years at least of management potentially or especially even younger, 55. The average age of my clinic is 53. So it's not that old, it's not old, young. Yeah. So I've got one other question here. What are your views on brain elasticity?
Plasticity?
Plasticity, yeah. So brain plasticity, well, it's a misused word. It's actually, everything is plastic, right? What does that mean? That means if you stimulate or change the environment within which anything is operating into your bicep muscle, it'll change its structure, it'll change its function, efficiency, right? So that's why if you exercise regularly, you'll become more efficient at exercising. So is that called plasticity? Yeah, it is basically that, right? And so in the brain, by definition, plasticity means it's always forming new synapses, resorbing synapses, connections are continuously being overhauled. That happens all the time. Now, what it is about an input, so exercise being the biggest one, that actually makes that system truly lay down brand new, concrete, strong, new connections, That's not being validated. And the reason it's not been validated is because we have no way to measure that in the brain, right? So somebody claims to you that whatever you're doing, whether it's luminosity or some exercise program or whatever, that's making an impact on your brain's plasticity, you know that that's incorrect because we have no way to measure that.
It's at best an inference.
That's right, at best. Association studies are a big problem because anytime you associate something with something else, unless you know the granularity, the accuracy of each of those measurements, and probably there are many steps in between, you can measure this and associate with that. It's often when you go down south to the U.S., farther south you go, people think Canada means snow every day. And that's not true, because at one time that they've come to Toronto, it snowed, which means that every time you come to Canada, it snows, and that association is incorrect, because the variables that were measured were incorrectly measured. And that's the problem with many things that are non-science, right? And that you measure it inaccurately. So the brain is plastic, for sure. Absolutely. Can we harness that to our advantage? That's the difficulty. Right? So.
Yeah, and we know lots from basic science research, animal research, you know, the old stuff about an enriching an environment and
Yes.
it changes
Yes.
cortical thickening and all that. So we know these things happen, but we don't
Absolutely.
have any way of measuring this now.
Yeah. So actually
with
this
our
morning I gave a couple of lectures at another conference that's going on at Ivy, and what I showed in that, one of the data sets that I showed was actually measuring thickness of the brain's cortex, which is the mantle that's on top of our brain matter. If you were to, let's say you had a stroke, right, and you immobilize one arm because of the stroke, and you start using the other arm more, right, because you've got the other side, that's all you've got. What we see in volumetric scans is that the opposite side of the brain, which is connected, the brain is connected this way. If my right hand is not used properly, then the thickness of the cortex on the left side decreases. But if I start using my left arm more now, the thickness on the right side increases. Right? So, but that's been known for many, many, many years. The thing is that whether that translates to functional improvement, right? So if I were a painter and I'm doing art on that side, can I now just make this? That's very difficult to do. Very difficult.
Yeah, indeed. Indeed. It looks like some of these questions that were
Already answered.
I think most of them have been answered. Is there anything down here that we should look at? We've answered. What are the symptoms? You've talked about that. Stages. I'm sure you talked about that. Bad to take medication with protein. We talked about that.
Why is there an age limit for Parkinson's disease? I'm not sure I understand that. There is no age limit for Parkinson's disease.
It's just a more common group.
Oh, no.
More questions. Okay, so, super. Right. No, keep it up. That's great, yeah. So why is there an age limit? Well, there isn't, as you say. There's no age limit. But there's a more common age occurrence.
Yes.
And we'd say, if you look at the distribution of age of onset of the diagnosis of Parkinson's, it's typically between 55 and 65. But we see young onset people, we see older onset people. There's a distribution. But there's no real age limit. I mean, I know you've had a very young person. The youngest person that I've seen in my practice was 24.
Yes.
Had diagnosed. You had somebody younger.
Younger, yes. We had, the youngest that I've seen is 9. And, this individual clearly doesn't have typical Parkinson's disease. We've seen 18-year-olds, we've published 30-year-olds, 25-year-olds, many. But the disease is not Parkinson's disease that we see in the 60s. That's why I don't think it's...
Yes.
Yeah, so these people have an inherited genetic form of Parkinson's disease most likely, right? And so that's not the same as idiopathic Parkinson's disease. But the answer is correct. There's no age limit at all for neurodegenerative disease, right? No age limit.
So I know you talked about a lot of these things, and I just wanted to add, because I mentioned the vascular idea, has there been any correlation in research showing strokes being a minor cause of Parkinson's? Well, not so much strokes causing, again, typical Parkinson's, the pathology of cell loss in the substantia nigra leading to unilateral first, then bilateral symptoms, no. But do we see Parkinson's variants that have strokes related? Yeah, this vascular Parkinsonism, often overlooked and an important thing to recognize and deal with.
So here it says, we have heard that levodopa pump works better than DBS. When will this treatment option be available? Could you see more effect? So that's not true, right? So DBS actually works exceedingly well. Duodopa pump is basically just levodopa, right? So in fact, we use duodopa pump therapy in those patients where we're not considering DBS, Right? So those people that are over the age of 72, 73, because we have an age cutoff for DBS, mainly because of two reasons. One is the anatomical placement of the electrodes becomes less and less reliable as the brain shrinks more and more with age. And so we have a human brain atlas that we take the patient's MRI and we kind of warp it to fit the atlas. But the atlas is a 55-year-old bunch of people that have no disease, right? And so the problem with it is that the older you get, the farther away you go from the atlas. And hence, when we need the coordinates to put in the electrodes, if you're far away from it, then we're going to get it wrong. The second is that with age, cognitive decline occurs, and one of the potential side effects of DBS can be worsening of cognition. Hence, after the age of 72, 73, maximum 75, 70 is really good, we would not do DBS. But that doesn't mean that we can't do duodopa in those patients, right? So duodopa we can do forever, as long as there are no GI issues.
You're answering this.
Yeah. So that's the. Most of the time, though, unlike DBS, duodopa has more restrictions. What does that mean? That means you have to have been tried on all the medicines that currently are available. So pramipexole, razagiline, et cetera, those drugs have to have been tried and failed, or at least the physician has to certify that they're not applicable to use, and then you get approval from the government. DBS, we decide, we put in the device when we do all our workup and put in the device, and that's it. Right? So, keep going? Yeah, there's one more question I'd like to, with respect tied into that is in terms of what is advanced Parkinson's, right? And so advanced Parkinson's disease is a misnomer because what is actually accepted as advanced Parkinson's disease in the definition is 6 years of disease and at least 500 milligrams of levodopa. And that's a no, right? So that means that almost everybody in my practice has advanced Parkinson's disease. In terms of what we say advanced, it really is a combination of those symptoms that are now worsening the quality of life beyond what we can help with the medicines that we have, right? So that means freezing of gait and falling, balance difficulty, cognitive decline, choking and swallowing, all of these things, urinary difficulties that are keeping people awake at night. So drugs that are currently being used for treatment are now not effective anymore. That could happen in somebody at 7 to 10 years into disease, but usually about 15, 18 years into disease. Yeah, exactly. The flip side of it is also true. I never tell patients because you've had 15 years of disease, you've got advanced Parkinson's disease, if everything is working well. Because there's a very large number of people in our practice where the drugs are working quite well at 15, 18 years into disease, and they're doing really well. And so do they have advanced disease? So time of disease is not something that I use, but symptoms that people have that are impairing their quality of life.
So there's such a bewildering array of change per person. So and I say this to people, everybody is their own case.
Control, yes. Yeah.
You can't make conclusions. So oftentimes you'll hear people say, well, should I go to a support group? And I say, well, a support group can be very helpful for you unless you have, unless there are things that bother you about that. Yes. But remember that when you see someone at a support group, you may or may not have those complications, or you may or may not do as well or as poorly as that person. Everybody's an individual, and we just have to manage the symptoms as they occur and try to do what we can to improve quality of life. And so that's I never think of advanced according to those to those diagnostic criteria. This is ridiculous because that's everybody.
That's exactly right. Yeah.
So. I'll move on to my next question. Yeah, absolutely. Is there research on a cure being done? Oh, hell yes. Lots. And there's I know you've mentioned it before, the Michael J. Fox Foundation, very huge organization now, getting money, soliciting money, getting donations, working with the U.S. government and here in Canada as well. And the prime motivating thing, I think, with the Michael J. Fox Foundation is search for a cure. And it's a very complicated thing. There's a lot of stuff going on at very many different levels. One of the things you heard Dr. Jog talk about was all of the different ways of making the medication that we know that works well right now get delivered in a better way and be more effective. That's one aspect. That's not a cure, that's symptomatic. But there's tons of other things going on at basic science levels and different labs all over the world
absolutely.
That are some things that are interesting that are becoming kind of bubbling up under the surface, things like CRISPR. We don't know how CRISPR is going to change what we're able to do with diseases, and it's a gene editing technique. So there are lots of things going on. So absolutely, there's a ton.
The problem with looking for a cure is that you cannot neglect all the other things that we can actually do to improve quality of life, right? So we can treat patients for 15, 20 years quite effectively, at least, especially with the new surgical. So what ends up happening is that you must find a cure. Yeah, well, but we haven't found a cure for diabetes either. But we've got really excellent management.
Right.
So if I can keep somebody that's 65 healthy and well and treat it for 25 years, we don't really need a cure tomorrow. We can make sure that our science is good before we actually jump to that, right?
Yeah.
Because what ends up happening is that a lot of money is spent there, but not on the fact that we really have good treatments. Right?
Yes.
Really do.
And we should do better, yeah.
Yes, exactly. That's it.
Well, a good analogy would be, your kitchen starts on fire, and instead of putting it out, dealing with the actual problem that's at hand, you start searching around for the electrical wiring problem in the basement. It's not really the best time to, and that's not a great example, but
Yes, it is.
but it certainly gets the notion that we want to treat the problems that we have, and let's not ignore those, because we've got medications and things and ways of dealing with the symptoms that can greatly improve quality of life and functionality. So,
absolutely.
And that includes medications and surgery and so on, as you've talked about. Mine, do you want to go or me?
No, you go ahead.
All right. So my question is it appropriate for a Parkinson's patient to have a nap or more than one nap at midday? And my answer is, oh, hell yes, I would do it myself if I could. Unfortunately, I don't have that amount of time. But there's nothing wrong with that. I don't
Afternoon
think
siesta? See?
the whole country in Spain does it.
Yes,
Not a
exactly.
bad thing. No, I think it's very fine. You work to your level of function, and again, it's about quality of life. What can you do? Can you get things done? Can you take some time off? Can you, rest up and go on and do more? Why not? Nothing harmful about it. Nothing harmful. The one caution that I would have, though, is sleep is like a glass. You can only get so much sleep in there, right? And if you fill it up in the day, you're probably going to be awake at night. And the joke that I always tell people when we start to get into sleep disturbance issues, you have two choices. Better sleep hygiene, stay awake during the day, or move to China. Right? Get back on their cycle. So you have to deal with the sleep. You can't sleep all day long. And that's another thing that I tell people is then, okay, if you're finding that you're napping and tired and sleeping all day long, be more active during the day so you can condense that into the night. Try to improve your nighttime sleep. Is it okay to have a nap? Yes. Is it okay to sleep all day long? No.
One other point I'll make about sleep, and that's a very special phenomena that occurs in some patients with Parkinson's disease. That's called sleep benefit. And what sleep benefit is waking up in the middle of the night at 3 or 4 and feeling that you're cured, right? And the reason that happens, and and this is the report in the literature extensively, and the reason that happens is during the night sleep stage, it is possible for some people to store enough dopamine in their neurons so that when they wake up in the morning, they have a residual store that for an hour or two, and that could be at 3 in the morning. But I've also had patients, and this is a cautionary thing, who wake up in the morning and feel really good, and then say, I took my levodopa at 8, and geez, I'm worse now. So your drug is actually making me worse. I'm going to stop it. And that actually is completely wrong. The reason is that you get that 1 hour of benefit from your sleep, and that's when I usually start right away with the first dose, right? And in fact, that effect of the morning sleep benefit is gone. And so you've lost your endogenous dopamine kick, so to say. So in the afternoon, sometimes I do recommend for those patients who tell me, because we ask everybody about sleep benefit, if somebody says to me that, yeah, you know what, I wake up and I'm actually quite good, then those patients, if they have a wearing off period in the afternoon, take a 20-minute nap, because you might be able to get that sleep benefit to come back again in the afternoon. Instead of taking an extra half a tablet or tablet if you levodopa, take a nap, because that has been shown and validated in the literature to be almost as good, if not as good, as taking an extra tablet in those patients that have sleep benefit.
Very much, yeah. That is a very common question. I feel so good after a nap. Why is that? Or after sleep in the morning, I feel so good, and I take your damn medication, I feel terrible. But it's not
because of that.
It's not because of the medication. It's because of what's happening.
Sleep benefit.
Yeah. Me?
No, go ahead. I'd like to participate in PD. This is really for us, and so I'm going to have to answer that with feeling a bit ashamed here, that we're not able to find out what studies that are going on in our labs, and that's true. I mean, we should do a much better job of on our website. We have the London Movement Disorder Center website. The problem is that there are other people that are doing whatever research that they're doing that are not associated with us, that I cannot put their research on our website. So we have a London Movement Disorder Center website, which is mine, all the research that we do in my lab that is available. Lots of other people are doing research, but they're not doing therapeutic research. So, understanding how the brain functions in this in a situation or that, that's fine, that's good stuff, and you can certainly participate, no problem. That's not therapeutic, and that's one of the reasons why I don't know about all those other research ideas that are being floated around. Maybe somebody is doing a research project that is studying how right arm functions versus left arm at the university. But I wouldn't know that because that's not something that has a treatment component to it. So we should do a better job of finding out all of it. If people don't tell me from outside of our group, then there's no way for me to know.
So here's a question that I will sort of do a little hand waving on the answer, but are there big and loud classes available in Canada? And I mentioned this idea of big and loud, and this is the idea about thinking about making big movements, thinking about, I always tell people to think about a marching band song in your head to try to use that cadence or sequence to get yourself moving and freezing. I have to admit, I'm not entirely sure if there's anything specific about a class. I know that there are YMCAs in my area in Cambridge and Kitchener have very good programs for exercise, and that will dovetail into one of the questions here. So I was always taught that when you don't know the specific answer to a question, just answer a question you know the answer to. So I'm not entirely sure that there are big and loud classes per se, but I know that the YMCA and other programs offer that, and support groups would be helpful in that regard. And again, Parkinson's Society Southwestern Ontario would be a good resource to look at. The question that is asked here, changing the topic, is what types of exercise are the most important for someone living with PD? And I think the bottom line answer to that is we're not sure entirely, just as we said, we're not sure about cause and effect and the efficacy and all that. But what we can say, and what I tell people to do about exercise, is I want 4 pillars of exercise. I want something that does work your cardiovascular system, get your heart rate up, something that helps you strengthen, so whether that's some weight resistance training, something that helps with flexibility, and then the 4th pillar of this is learning new things. And I tell people about learning new things, and that's where things like boxing comes in, or dancing comes in. My favorite, golf, rather than those things. Dancing is a very frightening thing for me in my head. It's because I'm genetically incapable. It's not possible for me. It's a sore spot. But the reality is learning a new thing, doing all those other things. So I tell people things like yoga, Tai Chi, Pilates, those things that make you learn new motor sequences. Make you do things, make your brain get around these short circuits. That's what I tell people to do. So.
Yeah, I think that's excellent, and I think I've been signaled that we're running out of time, Dr. Stewart. And,
right.
So I hope that hopefully we've at least tackled most of the questions that are here. And we would want to stop now.
You know what, if I could answer, I'm so sorry.
Okay.
This is an important one I don't think we should miss. It's about anxiety and depression.
Oh, yeah, sure.
Okay. So as a caregiver, what's the best way to support Parkinson's patients struggling with anxiety and depression? You know what, bottom line is make sure we know about it.
Yes.
Let us know, because there's a stigma, everybody knows about this stigma, but nobody wants to talk about that. No, I'm not depressed. No, I'm not depressed. If you feel that way as a caregiver or as a patient, let us know, I do joke about it sometimes and say, you tell me a problem, I can throw a drug at it, but that's not the only answer. The answer is, if there's a problem, don't be afraid to bring it up. We want to talk about that.
Yes.
We got to talk about that. So I didn't want to miss that one.
No, I think that's absolutely. Non-motor symptoms. You have a comment?
Huge.
Okay.
Due to the complexity of administering legal, should we always get a prescription from a specialist? I mean, I don't want to go to my GP.
No, so the prescription, so I would say that no family physician, internist, geriatrician really, unless they're specialized in this field, should be starting people on medication for Parkinson's disease. Right. Yeah, I don't think that's a good idea.
Right. I would echo that and much prefer that, because the potential for, maybe misrepresenting essential tremor versus I'd really want that person to be seen before it started. Yeah.
And we often see people are given 2 or 3 times a day, or half a tablet and some wrong pill, and then they're told that it doesn't work for them. And now and in fact, what Dr. Stewart mentioned in terms of the other Parkinsonian syndrome, one of the things that we use as a guideline is lack of response to levodopa. So if somebody is given inadequate amount of a trial of levodopa, just even yesterday, one of the residents with my clinic from another service said that, oh, well, we can make a diagnosis. Let's give 2 tablets of levodopa now and see if it works. I mean, whoever taught this person needs to go back to school. It's terrible. This is wrong. But that's actually out there, right? And commonly. And so what ends up happening is if those people misuse, then the diagnosis is made wrong, and then people are told they've got a bad disease, they don't have any treatment. It's all wrong, right? Yeah. Right. Dr. Stewart, thank you. Good one. Well done.
That's a strong friendship right there.